So we can go ahead and get started. It's my great pleasure today to welcome you all to the ASCP Virtual Pathology Grand Rounds. My name is Sarah Wobker, and it's a real pleasure today to introduce our speaker, Dr. Eva Wojcik. She's currently the Chair of Pathology in Laboratory Medicine and an endowed Professor of Pathology and Urology at the Loyola University Medical Center. Before she took over as the chair in 2007, she was the director of the APCP residency program and also the Cytopathology Fellowship. She's a past president of the American Society of Cytopathology, and currently she's the vice president of the College of American Pathologists Foundation. Dr. Wojcik graduated from the Medical University of Gdańsk, Poland, and completed her residency in anatomical and clinical pathology at Wayne State University in Detroit, followed by her cytopathology fellowship at MD Anderson Cancer Center in Houston. Dr. Wojcik is a very well-known speaker, frequently invited to speak at numerous international, national, and regional forums. Most of her presentations deal with recent advances in urine cytology, and most importantly, she's led international efforts to standardize the reporting of urinary cytology, which culminated in the publication of the Paris system for reporting urinary cytology. She's authored and co-authored over 200 articles, book chapters, and abstracts. And in 2019, she was awarded the highly prestigious honor of the Loyola University Faculty of the Year. So on behalf of the ASCP VPGR committee, which includes myself, Raul Gonzalez, Sarah Zhang, Elham Kanafshar, Kamran Mirza, we're very honored to host Dr. Wojcik for today's event, which is entitled To Atypia or Not to Atypia? That is the question. So thank you very much. I'll turn it over to you, Dr. Wojcik.
Thank you, Dr. Wobker, for this very nice introduction. And the most important, thank you for inviting me to present this virtual grand round. And today I will be talking about atypia, my favorite subject to talk about, but definitely not my favorite diagnosis. I have a book royalty. I received book royalties from Springer, so this is my disclosures. So during this presentation, before we're going to start talking about atypia, let's talk about us. Let's talk about what is the role of a pathologist, who we are, and let's talk about pathology reports. What would be the ideal pathology reports, and unfortunately, what is the real life pathology report? Of course, we're going to talk about atypia. What is the atypia? And of course, atypia in cytology. And obviously, I have to tell you the urine story and the creation of the Paris system. And hopefully, you are all aware that we are in the final stages of our work on the second edition of the TPS. And it's going to come in soon, hopefully. So I will present what is new in the TPS 2.0, highlighting all the changes and improvements, we hope. So who we are pathologists, and let's see how we are being seen by the world. So I just did a simple Google search, and these are the definitions I came across. A pathologist is a physician. Well, that's good. At least we are being recognized that we are indeed physicians in the medical field who studied the cause, nature, and effects of the disease. Is this what we are doing daily? I kind of cannot describe myself that this is what I'm doing. Pathologists are specialist physicians that undertake research and testing of medical specimens for the diagnosis and treatment of the disease. It's getting better. At least there is something about that diagnosis, because that's exactly what we do. And the next one, pathologists are physicians who specialize in the diagnosis and management of human disease by laboratory methods. That's pretty close. And the bottom line, you know, what we create, and we create reports, and this is how we communicate. When we really think about, except us cytopathologists and transfusion medicine physicians, most of us don't have a direct patient contact. We do not really communicate directly to our patients. The way how we communicate to patients, and most important, to our clinical colleagues, are our reports. These are extremely, extremely important. And of course, you know, that's what we keep hearing all the time. We are the doctor's doctor. And I personally, I kind of have a problem understanding what does that mean. So if we're talking about reports, what ideal pathology should look like? In my mind, an ideal pathology report should lead to clear action. For instance, something is positive, it will lead either clinicians know what to do. If this urine cytology is positive, they have to follow with the biopsy, not that because they don't trust us, but they have to know exactly where is this tumor, and the most important, the stage of the tumor. What kind of management they have to apply. Positive report leads to surgery, chemotherapy, molecular studies, etc. It's clear, they know what to do. Same with negative, either negative reassurance observation, or if this does not make sense that there is indeed some lesion and report came out negative, meaning lesion simply was not sampled properly, it has to be repeated. They know what to do. Cut or not cut, clear action. So this is the ideal, black and white. We know that life is not black and white. Reality, there is a lot of grays in between. This is life, and this is also pathology. We have somehow be able to differentiate between this, where is the positive, where is the negative, or is it possible? And that brings me to this doctor's doctor. Years ago, most probably way over 15 years ago, I was sitting in my office with Dr. Amit Kini. He's one of our faculty, and we were talking about what we do. And he came out, I wish I could come out with this. And I thought that was the best definitions, what is the pathologist? We are the translators of analog reality to digital minds of clinicians. This is really, instead of, this is the word, this is the reality. Reality is analog, pathology is analog, and this is the mindset of the clinicians, especially surgeons. Cut, no cut, no cut, 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 no cut, cut. Clear. So somehow we have to translate this analog reality into the actionable digital minds of clinicians. And of course, it's not easy because, and that even applies to the clinical pathology. This is that classic graph showing you the PSA level and how the cutoff time of 4.0 was achieved. And with the understanding, at least in our mind, that there's always going to be some false negative and false positive results. But there is this magic 4.0, which was achieved by testing and generating this receiver operating curves, trying to figure it out what is the best cutoff time. And that's practically, as we all know, all the clinical pathology, how it really works. But to some extent, as you will see, occasionally can be applied in anatomic pathology. But anatomic pathology, and of course cytopathology, this is the reality. This is the hope of any classification or anything to have a positive or negative, whatever the area and specialty is. But this is the reality. We're going to have two extremes, which are relatively easy. Very positive is always easy, negative is easy, but this area in between that indeterminate categories, suspicious of atypical, which are kind of potentially confusing for the clinicians, and quite often in their minds, it implies that maybe we don't know. My answer is no, we just know much too much. And we know what are those exceptions. And that's why there's this category of atypia and suspicious. So in my mind, when I'm thinking what is the making diagnosis is really deciding at which point I'm going to call something negative and which point I'm going to call this atypical. So it's simply drawing lines. And we all hope those lines going to be drawn based on criteria, data, evidence, experience. But we know in reality, quite often is based on our feelings, gut feelings. I just don't like this case. I don't know what it is all about, but my gut is telling me that I cannot call this negative. It works. I mean, that's how we operate quite often, realistically speaking, but that doesn't sound very scientific. Time of the day, in the morning, when we're all fresh, everything is black and white, everything is clear. With the time progressing and getting closer to that 5 o'clock, everything is blurred, getting grayer and grayer and grayer. Turnaround times are important. We have to clean this pile of cases, so atypical. Personality, you know what I'm talking about. There, each and every institution have that person who always going to find that one cell. It's so atypical, I cannot call this negative. Work environments, etc., etc. This is the reality. So that brings me to this amazing paper written by our incredible Stefan Pambuchian, who unfortunately for all of us passed in December. Stefan was one of the most brilliant pathologists I had ever honored to work with. He has read everything. Incredible thinker and great, great writer. And I really would advise any of you to read this paper. It's so thoughtful. So, of course, about atypia. So this is exactly what we were saying before. What is atypia? It's the filling the gap between obvious, between positive versus negative. There is, in general, no clear criteria when, in general, except some few areas, we are operating mostly on those gut feelings. And of course, level of education, experience, and that personality. Atypia is not an entity. And when you really go to the dictionary, there is really not good definition. Atypia comes from the Greek words a plus typos, which really means without type, a condition of being irregular, non-standard, nothing more, as little precise as possible, more or less. And this is directly citing the paper of Dr. Pambuchian. Atypia is a term intimately associated with practice of diagnostic cytopathology, unfortunately. And it's so ingrained into cytopathologist's vocabulary that he or she hardly stops to think about its meaning. You know, those of us who practice cytopathology think about this. We constantly use this term. And I'm going to be using unconsciously, I know, even as much as I'm trying to stop using this, when I'm going to be describing some cases. So Stefan has done kind of mega search looking at the titles in pathology literature, looking for a term atypia in those titles. And in cytology literature, almost 2.3% of all cytopathology literature use the word atypia in the title, as compared to 1.26 in surgical pathology and only 0.1 in general medicine. And this is, I think, the most striking thing. No single publication addressing the meaning, origin, and evaluation of the term atypia and its use in diagnostic cytopathology has ever been published. Yet, we are using this daily. So what to do with this? So obviously, we don't want to do this, but somehow we have to accept and or at least try to standardize. This is the process we have followed with Paris system, but retrospectively looking at the other system, it's similar. Practically each and every group use similar process. So how to define atypia in cytopathology? First, and I think the most important, we have to define what is not atypia. And set a diagnostic criteria which will be based on evidence and consensus. Set acceptable rate. What is the frequency? What is the expected, how often can we use this? Establish risk of malignancy and define the management. So going back in time, looking at the Bethesda system for cervical cytology, this system has been around with us for years and years, and it's been widely accepted by the entire world. And when you look in this book, there is a significant portion of the book devoted really describing what is not atypia, what is not dysplasia. All those negative diagnostic entity, but very specific entity. And all of them, when you look at that, they all look so-called atypical. They don't look like normal squamous or glandular cells, but we know why they look like this. Here's the beautiful example of repair, cohesive, two-dimensional fragment of tissue and the cells showing this characteristic streaming and very prominent nucleoli, classic repair. Chemotherapy changes, significant increase in nuclear size, multinucleation, binucleation, polychromasia, maintain NC ratio, transitional cell metaplasia, the very significant pitfall for HSIL, showing cells which are very high NC, again having high NC ratio, but nuclear membrane are smooth. They have very characteristic those grooves, and also notice those small halos. Tubal metaplasia, pitfall for AIS. Always look for cilia, always look for terminal bars. IUD, very abnormal looking glandular cells with this vacuolated cytoplasm, with the history of IUD. This is exactly consistent with atrophy. As far as I'm concerned, each and every atrophic smear looks atypical. Quite often we see big tissue fragments, again, very uniform cells with smooth nuclear membrane. And something to kind of pay attention, lower uterine segment can be quite worrisome because we can have this big tissue fragments, but notice they are very cohesive, so relatively small cells, and the configuration is very important. Somebody said like a detached sleeve of a jacket or a shirt or something like this, exactly like this. So again, all of them look atypical, but we know why, and therefore they are simply negative. So now the definition. In cervical cytology is relatively simple because we have only two types of cell, squamous and glandular. So definition, cytologic changes suggestive of SIL, but which are qualitatively and quantitatively insufficient for a definite interpretation as such. And now this is very important. They give this very precise numbers, something which we can, really relate to and say, with confidence, yes, this looks like ask us because the nucleus is about 2 times larger than the next nucleus of the normal in the intermediate cells. So there is a specific kind of measurement, specific morphologic features which we can all follow and therefore standardize our reports. And the same applies for ask age. And similarly, they are quite specific description how and definition for atypical glandular cells as well. And again, Bethesda has been with us for almost forever, so there is tons and tons of data. We know what is the frequency from about 1.6 to 9%. This is expected frequency. And of course, very much depends on the patient population, your practice. What is important that there is well-known relationship between ASCUS and SIL. This ratio is part of the quality control measure. So making sure that, you know, the differences between population is accountable for. We have a more molecular independent factor which can tell you ask us the significant or not. And of course, you know, considering that has been with us for practically forever, and there is data, there are clinical data, there are follow-up data, so there are very clear guidelines what to do and how to manage patient with ASCAS, ASK-H, as well as atypical glandular cells. So this Bethesda system for cervical cytology is really the kind of guide for all of us how to create the reporting system. So the next one was thyroid. And in reality, thyroid was kind of similar like this. There was description of what is not atypia, recognizing that big tissue fragments can happen in completely negative finite aspiration of the thyroid. Graves' disease, it's, you know, if we have the clinical history, we can understand that those very abnormal looking cells are just special in those patients who have been treated. That's the reason why we have those atypical changes. Hurtle cells, one of the most important to recognize this cyst lining cells. They are usually very scary and very abnormal looking, but again, finding the evidence there are cystic changes, we are fully aware that this is again normal, well, not atypical, that does not require for us to call this atypical. And lymphocytic thyroiditis, almost by definition, they're always gonna have some reactive changes. At the same token, we know that there is an increased frequency of papillary carcinoma in patients with lymphocytic thyroiditis. So therefore, again, this atypia can potentially, these changes can be quite tricky. So now the definition, we know that there's a separate diagnostic category, atypia of uncertain significance. And again, consider this is not, this moment we are not dealing with only two types of cells, because follicular cells, lymphoids, and others. So the definition is not that specific, I would say. So specimen that contains cells with architecture and or nuclear atypia that is not sufficient to be classified as suspicious for follicular neoplasm, suspicious for malignancy, or malignant. There is I would say, lots of room for interpretation. And these are the examples from this book. Notice that Hashimoto thyroiditis is also included in the atypical category. So this is again interpretation for us, and which point, and based on our experience, I would say, our personality, we're gonna draw that line that this is just pure Hashimoto versus AUS, and the same would apply with Graves' disease. The rate and frequency, the atypia or follicular lesion of undetermined significance, appropriate expected frequency is about 5 to 15%. And normally, malignancy rate was about 5 to 15%, except right now, of course, you know, everything to, right now it's about 5 to 15%. Everything has changed with the introduction of the NIFT-P, when you can see especially the risk of malignancy pre-NIFT-P and post-NIFT-P significantly has changed. It's really affected this. But again, we also, for the clinic, our clinical colleagues, it is, you know, clear what to do next. With the diagnosis of atypia or FLAS, it's either to repeat FNA or ultrasound, or in certain cases, follow up with lobectomy. Now, let's talk about Milan system. Milan system dealing, this is of course salivary gland cytology. Salivary gland cytology, very, very complicated area. And I'm still, you know, amazed how they were able to put this into one logical reporting system. So of course, in salivary glands, we're going to have non-neoplastic lesion, and we have, once we recognize this, this is definitely not diagnostic category of any atypia. And of course, we have to recognize neoplastic lesions, which are benign. So here's example of granuloma silodenitis. This is again just simple granuloma, therefore it's negative, non-neoplastic, simply silodenitis. An example of Warthin's tumor, nothing to say more, is benign neoplasm, Warthin's tumor, that's it. In Milan system, there are kind of two indeterminate diagnostic categories. There's atypia of undetermined significance, or AUS. In reality, this is really reserved in majority of the cases where there are some pre-analytical problem, either poor sampling, fixation, low cellularity, or artifacts. Like here, there's some cluster of squamous cells with some orangophilia, keratinization. Is this potential? But you cannot read this. It's very sparsely cellular. Is it metastatic squamous cell carcinoma or just squamous metaplasia? You cannot ignore it. Therefore, if you think about potential, it could be squamous cell carcinoma, and I think it's justifiable to put this in this atypical category. Warthin tumor, most probably, but are we going to make the diagnosis based on 2 oncocytic cells in the background of lymphocytes? Again, so we cannot completely discard this. So potentially atypia of undetermined significance. There's also another diagnostic category, a famous SUMP, salivary gland neoplasm of uncertain malignant potential. So in this case, we know it's a neoplasm, but that's the only thing what we can say. We know that this does not belong to the salivary glands. This is nothing reactive. This is something, new, neoplastic. But we don't know if it's malignant or not. So, and majority of the cases, like in this one, is a monomorphic cell type. So, what is really right now, especially risk of malignancy and histologic correlation? Based on this retrospective 12-year study, you show that risk of malignancy in cases which were diagnosed of atypia of undetermined significance was very significant, close to 40%. But we have to understand this cohort of cases, these are only cases which follow up with surgical procedure. So clinically, of course, it was already high suspicion that something has to be done. There is a possibility of neoplasm, and particularly malignant neoplasm. So this is indeed very significant diagnosis. In the other study, also from 2019, when they look at all the cases, so atypia of undetermined significance, risk of malignancy was about 20%. And the management, repeat FNA or surgery. So the bottom line, again, it's a significant diagnosis in the respect that there has to be some action after that. Maybe not very clear, but at least repeat FNA or surgery based on the clinical presentation. So now pancreatobiliary cytology, that was one of the earlier system. And if salivary gland was overall area was complicated, tell me about the pancreas. This is in general very, very difficult area. So again, we have to do everything possible to think, what is negative, what circumstances we can call this simply negative for malignancy. One of the main issue is the GI contamination and in general benign pancreatic tissue. GI contamination, I remember when we started EUSs, that was driving me crazy. I didn't understand what are those cells, and especially those parietal cells in those FNAs which were going through the stomach. I was telling, they kind of, especially if they're single, they had a relative abundant cytoplasm, they're relatively dense, and they look like a squamous cells, what these squamous cells are doing in the pancreas. Going back to histology, checking how the histology of the normal stomach look like, that's That's what they are, just parietal cells. So we have to be able to recognize all the benign, not only benign pancreatic tissue, but also benign, stomach and GI contamination. Pancreatitis, acute, chronic, autoimmune, pseudocyst. But again, something to think about always, it's splenial or accessory spleen. We don't think about this right away. Lots of kind of lymphoid cells. Couldn't this be some kind of abnormal lymphoid proliferation? Cell blocks would be very helpful. And whenever we see crisscrossing capillaries, think about accessory spleen. And in general, we're only going to make the diagnosis of anything if we think about this. So how about the definition and criteria in the book? Cytologic specimen categorized as atypical demonstrates cytologic and architectural aberration greater than that clearly recognizable as reactive atypia, but less than that characteristic, those associated with category suspicious for malignancy. So again, lots of room for interpretation in cases like this, and it's really inherited with the type of the specimen they're dealing. So what is very important to have the examples, what the authors and experts in the field consider as atypical. So here this from the book: nuclear enlargement, parachromatic clearing, prominent nucleoli, slight nuclear crowding. This is, according to those who wrote those chapters and the book, considering that in appropriate, again, clinical setting will be justifiable to call this atypical. And now talking about the rate of the and frequency, as well as the risk of malignancy. The big, really kind of mega paper evaluating this issue has been recently published in the Journal of American Society of Psychopathology by Mauro Saig. And you can see, based on published literature, the rate of atypia is kind of vary from 0 up to almost 14%. And again, notice that this category clinically is very significant. Even on those very subtle, very minimal changes, you notice that the risk of malignancy is very, very high, except maybe still 40%, I think it's a significant risk of malignancy, but that was from the study which had the highest rate of the highest frequency. And the latest one is the serous fluid cytology. I was the one who was leading the chapter on negative for malignancy. My co-author, who is also here, Dr. Yang, we work on this together. So that was also, this chapter again was very important, really kind of to show what is not atypia. And I'm not going to go through this kind of algorithmic flow, how to approach this serous effusion, but I wanted to show that those unexpected findings in form of, if we recognize some about the collagen balls, LE cells, that, infectious organisms, this is all negative for malignancy. What is, I think, the most difficult when we have this increased number of cells, especially mesothelial cells, with all those reactive changes. And once we have used immunohistochemistry to exclude secondary malignancy like adenocarcinoma or mesothelioma, there is no reason to call this atypical. It's simply negative for malignancy. Like cases like this, these are just reactive mesothelial cells. But again, in many instances, we would have to use immunohistochemistry to exclude malignancy. I want to point out to histiocytes. Whenever I talk about fluids, I'm really stressing the importance of those histiocytes. This is the best example how, again, atypical they can look like. They don't read any books. Histiocytes should be single, and they kind of cluster together in those fluids, and they really appear like a second cell population. Immunohistochemistry would be very helpful. And just another example, endosalpingiosis, always look for cilia. Beautiful example of rheumatoid pleuritis, collagen ball or LE cells. All of these are present in this book. In this system, there is also the diagnostic definition of the atypical cells. Again, a fusion specimen that lack quantitative and qualitative cytologic features, etc. Again, lots of room for imagination, I would say. The most important recommended frequency rate is 5 to 15%. I would even say that 5% in my mind, it's relatively high. All my life, I was under impression that we never ever make the diagnosis of atypia in fluids, and only with extreme situations. And risk of malignancy based on the study is still relatively high. So talking about the rate of atypia, this is experience at Loyola. A few years ago, we look at our results, and you see overall percentage was 2.4, and the highest percentage was so-called abdominal. I think that was really peritoneal cavity, etc. So as a group overall, our rate of atypia is very low, and we look also how we differ among each other. So as in general, as long as we are within those 2 standard deviation, as a group, we are doing fine. So we have one outlier here, and me as another outlier to balance, I guess, for the group. But overall, I think, even in our outlier is way below even recommended rate. So it is achievable. Again, show the cases around, do immunohistochemistry, and correlate with the clinical and radiographic findings. And I think the rate of atypia can be very low. And of course, now, as I promised, I have to talk about the urine story and creation of the Paris system. I could not resist not to put this picture to show you that Paris system indeed has been very successful. There is also additional Chinese translation as well, and in really truly record time, it has been implemented and accepted by most of the world. What led to Paris? I think one of the most important was this. Everybody kept telling me, I hate urines, I hate urines, I hate urines. Doesn't matter what I'm gonna do, I'm always wrong. I'm gonna call negative. Apparently there is some small low grade. I call something positive, and they say they don't see anything. Of course they don't see because there's carcinoma in situ. Most probably you were right, and they have to keep looking. But really the most important, the rate of atypia before Paris was ranging from 2 to over 50%. So frankly speaking, we were in the verge of completely losing urine cytology. Our credibility was dwindling with the eyes of our clinical colleagues. Wide interobserver variability, there was, my atypia was definitely not yours. There was no reproducibility, etc. At the same time, just before Paris, lots of us were working and trying to figure it out. What can we do to fix this problem? What are the morphologic features would be helpful to predict a significant disease, meaning high-grade urothelial carcinoma? But this is the most important, the rate of atypia. And in Paris, we consciously went going through all those steps, starting with what is not atypia. And some people may say that we are in much better position because practically speaking, we are only dealing with one type of cells, urothelial cells, indeed. But those urothelial cells, particularly umbrella cells, can be very, very creative. Look at those 9 images, all of them completely normal. Yes, reactive umbrella cells, and they are really, they are small, large, humongous. Look at this cell right here, 1,000 times bigger than the next one. They can be multinucleated, binucleated, they can have single nucleus, The nucleus can be small, can be large, but they're all the same kind of features which bind them together. Nuclear cytoplasmic ratio is low. There's this very characteristic scalloped edges. The cytoplasm appears vacuolated. The nuclei are centrally located, and the nuclear membrane is smooth and defined chromatin. All of them completely, none of them requires to say atypical cells present. And just before Paris, I published this review paper in JASC, kind of summarizing those findings, talking about umbrella cells with XRT changes, polyoma changes. Once we recognize that it's polyoma, it is negative. Occasionally, we can see very atypical degenerated cells associated with mature spermatozoa, indicated that these are most probably seminal vesicle cells. This is again negative. Any ileal conduit or neobladder will appear again atypical because these are degenerated glandular cells exposed to this very toxic urine environment. They are dying, they are degenerated, and of course, they appear almost atypical. Occasionally, we can see granulomas. Again, just simply by the fact that they're in the urine where we do not expect, this is atypical findings, but it's just completely normal granuloma. So that was summarized in this chapter, which was led by Dottie Rosenthal. So finally, what is atypia? If we know what is not atypia, what is atypia? We know that polyoma is not atypia, but what to do fragments where this very high NC ratio, practically speaking, we cannot see even any cytoplasm. So at which point we're going to draw those lines and based on what? And the other issue, which I'm not going to cover that much today, how to differentiate between and positive and suspicious. How many cells do we really need to differentiate between those two? What are the criteria when and which point we're going to draw those lines? I mentioned that before Paris, there was a lots of activities in the literature. All of us were trying to figure it out. What are the morphologic findings going to be important to predict malignancy? And those groups who were working on atypia category and suspicious were reviewing all the literature. And by review of the literature, practically all of those came out to the same conclusions. Nuclear cytoplasmic ratio, high nuclear cytoplasmic ratio, extremely important. Nuclear hyperchromasia, coarse, clamped chromatin, and irregular nuclear membranes. So that was part of the success. We know what is important. If we have everything, obviously it's going to be positive. But now how we apply these findings to differentiate atypia versus suspicious. So after the even publication of the Paris, the group from Hopkins came out with this very, very important papers when they look at the cases which were originally diagnosed as atypical, those which follow-up was positive for high grade versus those which were negative. And they showed that the most important discriminating factor was indeed nuclear cytoplasmic ratio with the threshold of 0.5. So 0.5 is really this magic number. 50% of the entire cells has to be kind of replaced by the nucleus. At this moment, we are at least starting into the atypia category. And that was exactly originally started in Paris, that NC ratio has to be greater than 0.5, and one of those other factors, other findings. And even with this not that perfect definition, the Paris system worked. And that really worked. The literature from all over the world showing that across the world, there is a decrease of rate of atypia. The only paper is from Spain, we're showing the increase of atypia, but talking to those authors, and we realized that they were looking into the basal or clusters of basal and intermediate cells, and they're definitely a pitfall for not to overcall this atypia. And that's going to be also emphasized in the new second edition. So what is Atypia? As far as I'm concerned, Atypia is nothing else. It's just a wastebasket. It's a, before Paris, the way how I look at it, there was this huge, up to 50%. Can you imagine half of your urine cases would be just called atypical? Huge wastebasket, which were thrown all those cases. So Paris came, we still have Atypia, much smaller and much more confined and defined. There is a lid, there are criteria. So no, we did not eliminate the gray zone, we simply define. We define where are those lines. So I keep telling over and over again that the second edition of the Paris system is coming. We are in the final stages. Many of chapters are practically finished. It has been an amazing experience. The group, we are meeting every few weeks. Thanks God for Zoom. We're Zooming along and we are still discussing. There are still some controversial issues, but you know, the goal of the Paris from the beginning that whatever we're gonna do, it's gonna be based on evidence, and the most important, based on consensus. And sometimes this consensus is difficult to reach, but that's our goal. So what are the highlights? In the pathogenesis chapter, we will incorporate the cancer genome atlas molecular characterization into the pathogenesis of low-grade and high-grade urothelial carcinomas. What is important, we will update performance data for each diagnostic category. There will be an extended discussion on the criteria of degenerative changes. This is something which we failed to do in the TPS 1.0. We did not address degeneration in urine, which we all know happens all the time. This is something very, very new. Those of you who are using the Paris system, you know that we introduced a new term, LGAN, low-grade urothelial neoplasm, and the diagnostic criteria to make this diagnosis is the presence of fibrovascular cores. And we know that this is extremely, extremely rare. Also, what is the most important principle of the Paris system, that we are concentrating only on the diagnosis of clinically significant disease, high-grade urothelial carcinoma. Therefore, our negative category is negative for high-grade urothelial carcinoma. Considering that this is the most important, that's the most important question we have to answer for our clinical colleague. Is there high-grade versus no high-grade? Therefore, we decided to incorporate LGAN into the negative for high-grade urothelial carcinoma category. So if you're going to have those very, very rare cases of LGAN, the first line diagnosis will be negative for high-grade urothelial carcinoma, and underneath that second line would be LGAN, low-grade urothelial neoplasm. We also revised cytomorphologic criteria for atypical urothelial cells category, suspicious for high-grade and high-grade. And this applies to NC ratio and number of diagnostic cells. We did not change. I will show you how we're going to rephrase this, because that was one of the most important kind of point of discussion, especially that NC ratio 0.7. This is not science. We are not telling that, you know, each and every urine has to be scanned, and using image analysis to measure NC ratio is a kind of using our eyes. So therefore, the numbers, although very important and based on evidence and based on the study, but I think we have to de-emphasize overall the numbers. And again, very significant, there is going to be a discussion on morphologic subtypes. We recognize that high-grade urothelial carcinoma is very diverse group. They are plasmacytoid, micropapillary, all those tumors which they do not particularly fit into our diagnostic categories. So there is discussion about those subtypes, and we also address the issue of hypochromasia. We recognize that very small subset of tumors, the nuclei can be hypochromatic. And of course, we recognize there are also fibrovascular cores in high-grade urothelial carcinoma. There is an entire new chapter on upper urinary tract, written by, led by Chris Vanderbush from Johns Hopkins. And there is a quite extensive discussion on, I'm gonna again call atypical squamous cells and their clinical significance. We kind of, again, never addressed this issue in the first Paris system. Cytopreparatory techniques chapter markedly expanded with the example of standard operating procedures that would really help those of us who are running cytology labs. Of significance, there is also a separate chapter on the established risk of high-grade malignancy. Just to remind you that although we had the ROMs in the first Paris system, but that wasn't based really on the Paris criteria. Now we have a few years experience of published data, and based on that, there is an entire chapter with the really risk of malignancy based on the Paris criteria. Notice also it's not ROM, it's risk of high-grade malignancy, because that's what we, of course, the Paris system is all about. There is updated management according to current clinical guidelines, and something at the end, new chapter on history of urine cytology. It has been written by Stefan Pambuchian. I think it's one of his biggest work he has done, the most comprehensive, the most beautifully written and illustrated piece of work, really. I mean, it's a piece of art, beautifully illustrated and really kind of open eyes for all of us, the significance of urine for medicine overall throughout the century. So kind of towards the end, this is really the summary of the Paris System 2.0 in one table. Diagnostic category, these are the diagnostic criteria. When I was telling that there is some, not changes in numbers, but there is de-emphasizing the numbers. So for atypical, what is required? It's required increased NC ratio at least 0.5 and one of those parameters. So it's practically the same. Instead of just emphasizing the number, it's increased NC ratio. The same with the number of cells. For suspicious, few cells with this very high NC ratio, 0.7, and for the positive, many cells with the high NC ratio. This is the frequency based on the literature, and the most important also, we had a survey we had a response from over 50 countries of people who are using Paris system, and this is the frequency of individual category based on the survey. Notice that it is expected that atypical urothelial cells category shouldn't be really higher than 15%, and we are almost, you know, I truly believe even 10% is achievable. And I know it's achievable because, again, not only at Loyola, that our rate of atypia is about 6%, Cornell, it's about 5%. So it is achievable, it's only up to us. And this is the risk of high-grade malignancy. And you can notice that that's a pretty good stratification. And atypical category right now, it's a significant category. It's nothing to be just swept under the rug. You know, there is a possibility, because when we're gonna call atypia, it is, you know, we are already thinking that there is a possibility of a high-grade urothelial carcinoma. So finalize this presentation, we talk about the role of pathologist, and in my mind, this is our role. We are the translators of the analog world to the digital minds of our clinical colleagues. Ideal pathology report should lead to clear actions. Real-life pathology report, it's not obviously that black and white. It's our role. It's kind of to decide in which point we're going to draw those lines. Atypia in cytology is present too much, but there are constant attempts to standardize approach and create criteria which would be standardized and reproducible and used by all of us. We talk about the Paris system, and I showed you the data and the proof that the Paris system has worked, and overall the rate of atypia has decreased throughout the world. And second edition is on the horizon. It's really coming soon, so stay tuned. We are hoping that maybe it's going to be on the bookshelves by end of this calendar year, but if not, early 2022. So with this, I would like to thank for your attention. I hope we have a few minutes for questions. If not, here's my email address, my Twitter handle. I'd be happy to address any of the questions or comments or suggestions. Thank you very much.
Thank you so much, Dr. Wojcik. That was a really fantastic overview of atypia and numerous organs. We do have one quick question that's easy enough. The name of the book that's being referenced that you're talking about, I think towards the end.
I'm talking about the Paris system for reporting urinary cytology. Oh, you have it. You are better than me. So this is the first edition, and the second edition hopefully is going to come soon.
I'm looking forward to it. So I did have a question as someone who signs up both cytology and surgical pathology. The use of atypia can be a little bit different between the two. So with these systems, Milan, Bethesda, there's less, I would say, freedom of using your notes to explain why you called it atypia. What is your feeling on sort of descriptive notes in cytology?
I think descriptive notes are always good because it's matter of how we communicate with our clinical colleagues. I think any reports, we always kind of have to pause and think what's going to be next, how they're going to interpret this. If you feel that will help the patient's management, definitely, that's fine. I think we all, with time, establishing relationship and understanding between us and our clinical colleagues, and they know our language, hopefully, and sometimes we need a little bit more description and more explanation, because after all, we all know each and every case is different. There is always something. I think none of the system role is to somehow restrict our ability to communicate. I think it's each and every system, the role is to kind of standardize and make us speak at least similar language. But again, there are always going to be some exceptions.
I agree. So I'm looking forward to, you brought it up towards the end in the second edition, when the paper came out about using nuclear to cytoplasmic ratio for your diagnosis of high grade. There's a lot of, I would say, inter-observer reproducibility issues with doing that just with the human eye. So, you said we're not going to have to do AI on every single case, but what is your insight about best ways to approach that in daily practice?
I did not put this in the presentation. We're gonna have a visual aids also, I think it's really once in a while we have to recalibrate our eyes, you know, like, because 0.7 is very, very high. That's for sure. And I think, you know, again, each and every case is different. None of us is that strict. We recognize that there is lots of high-grade ureter carcinoma that majority of cells gonna be relatively low NC ratio. But that's the whole, you know, just for the sake, you know, find few of those cells with the high just to make sure that it's, you know, right. But the bottom line is, we all know those truly positive cases, and that does not apply to urine, applies to anything. None of us is really kind of thinking about the criteria. Is this gonna fit? Is this gonna fit? You put the case on the stage and you know it is. But it's really those cases where there you are on the edge. Is this malignant at all or not? This is where the criteria are coming and getting, you know, are important.
Great. All right. I'm not seeing any more questions from our attendees. Thank you all for joining, and especially Dr. Wojcik for volunteering for this talk. And since it's 3 o'clock, we'll respect everybody's time. And thank you all so much for attending. And on our behalf, we're very appreciative of your time.
And thank you for your attention, and thank you for invitation. And that was a pleasure. Thank you.